Good afternoon. Welcome to the ONC Health IT Certification Program Developer Roundtable. My name is Jennifer Gillison. I'm with Kaufman & Associates, and we'll be supporting today's session. Before we begin, I'd like to highlight the main features of the Zoom webinar interface. At the bottom of your screen is the Zoom menu bar. Here you will find the Q&A box. We encourage you to use this feature to submit any questions at any time during the meeting. We will leave some time for question and answers after the presentation. If for some reason you have a technical issue, please also type it into the Q&A and one of our technicians will work with you to resolve it. Additionally, live captioning is available during today's broadcast. Simply click the CC icon from your bottom menu bar to use the feature. Please be aware that today's meeting is being recorded. And with those announcements, I will now turn it over to Rob.
Thank you and welcome to everybody. Thank you for joining us. This is our inaugural ONC Health IT Certification Program Developer Roundtable. My name is Rob Anthony. I'm the Director of the Certification and Testing Division here in ONC's Office of Technology, and we collectively run the ONC Health IT Certification Program. We are hoping to host these developer roundtables on a fairly regular basis, hopefully quarterly. And the purpose of these meetings is really to engage with you, the developer community, provide some program education, talk about clarifications that may have been made around certain certification criteria and policy related to program requirements, provide any important updates that we may have about deadlines or program resources, and ultimately to engage in some topics for discussion that we want to hear from you about as well. So next slide. This is our standard legal disclaimer. This is an education session. Nothing in this should be taken to supersede what is a requirement within regulation. You will see ONC puts this disclaimer on everything. This is meant as a additional explanation of guidance. The regulation is always reigns supreme, so always refer to the regulation for those type of clarifications. Next slide. We have a pretty full slate. We're going to talk a little bit about real-world testing plan submissions. For those of you who haven't done it, that is right around the corner. We want to talk about the new CHPL developer access function, and then we have some things about some specific criteria that we have some clarifications around that we want to make sure that everybody is aware of. And then hopefully a little time at the end to sort of get some feedback from you about maybe what some of these new developer sessions can focus on. The coming year, 2022, is a big year for all of you as developers. There are new requirements related to Cure's update. Most of the new requirements for both new criteria and updated criteria have to be implemented by the end of the year. And we want to make sure that we are giving you all of the information that you need as developers as a whole. Next slide. I do want to say that we are going to do the best that we can to go ahead and answer what we can in the Q&As, but of course, we have JIRA is our main source of intake for any program-related inquiries. So if you don't see something that you need addressed here, or if perhaps something that you need addressed is a little bit more in-depth, please go to JIRA, send that question in so that we can track it and make sure that you get an answer. Here's today's speakers, and I just want to briefly introduce the folks that'll be on the call today. This is a portion of our team for certification and testing. Sean Spurlock, who is our communications guru and works in our program administration branch. Sarah Clark, who is our senior advisor, and I think many of you know from her years and years of work here. Papia Paul, who is one of our CHPL gurus and the lead in that area for program administration. And although I'm introducing all of these folks sort of together, just because they are in tools and testing, each of them does a critical function. Johnny Bender, Keith Carlson, Emily Hugh, Scott Bowen, they work partially as what we call our G team, which is our team of tools and testing subject matter experts that work on the G criteria like API. But you will notice that they work on a number of different criteria. Emily is our B3 e-prescribing guru here. So they may introduce themselves as they go through, but I did want to take a moment to thank all of them for talking with us today. And I will go to the next slide and turn over to whoever is next.
Thanks so much, Rob. This is Asara Clark with the Program Administration Branch and Certification and Testing Division. As Rob mentioned, I'm a senior advisor and also lead on real-world testing. So I'm just going to take a few moments to go through what is real-world testing, what and who it applies to, just to give a brief refresher, and then also going to talk about deadlines and timelines, publicly available resources to ensure that everyone is meeting their real-world testing requirements. Next slide, please. All right, so just as a refresher, what is real-world testing? As you all probably already know and are familiar with, real-world testing is a process by which you health IT developers will demonstrate interoperability and data exchange functionality of your certified health IT in real-world settings and scenarios. Rather than in a controlled testing environment, real-world testing is going to verify that when deployed, certified health IT continues to perform as intended and required by its certification and the scope of the certification criteria included within. These observations are going to be described in a public and transparent way through health IT developers describing their approaches to real-world testing and real-world testing plans to be made publicly available, and they're also going to report out on real-world testing results. And so successful real-world testing is going to mean that your certified health IT continues to be compliant with the certification criteria, including the required technical standards and vocabulary sets, that it is exchanging electronic health information in the care and practice settings for which it is marketed for use, and that the electronic health information is received by and used in the certified health IT appropriately. Next slide, please. All right, now who is required to conduct real-world testing? That is all of you who have one or more of the applicable certification criteria included within your certified health IT modules. I'm going to go over what those criteria are on another slide to come, but you just want to make sure that you're familiar with the real-world testing certification criteria and that to make sure that you are adhering to your condition of certification to successfully conduct real-world testing. As a part of the condition of certification, we have maintenance of certification requirements where the health IT developer must submit a real-world testing plan to its ONC ACB by the date that the ONC ACB has identified to enable them to be sure that the plan, the URL to the plan is publicly available on Chapel by December 15th of each year. You're also going to have to submit real-world testing results to your ONC ACB by a date that enables them to make those publicly available on Chapel no later than March 15th of each calendar year, and to notify your ONC ACB of any nonconformity with real-world certification program requirements during your real-world testing. Next slide, please. All right, now these are the applicable real-world testing criteria. So just want to take a moment to be sure that if you have any of the criteria listed on this slide and have not been working with your ONC ACB to submit a real-world testing plan, that you contact them immediately as the December 15th deadline is approaching in just about a week to ensure that you are not non-compliant with this condition of certification to have your real-world testing plan available on Chapel by the 15th of this month. Next slide, please. All right, now what health IT module should be included in your plan each year? This is a visual that just kind of describes this. What real-world testing, the plan is intended to describe approaches for the immediately following calendar year. So as you can see here in this example, if we're talking about the first year real-world testing is required in 2022, you will note that any certified health IT or any health IT certified by or before August 31st of this year, 2021, would need to be included in the 2022 real-world testing plan. Okay, that plan that I'm talking about, which is due on the 15th of this month, is to address the immediately following year of 2022. So all health IT modules that have been certified as of August 31st of the year for your next, I'm sorry, all health IT modules certified as of August 31st should be included in your next year's real world testing plan. So that's what this image describes. And you'll see that in the gray shaded area towards your right, those test results that are going to come out of your 2022 real world testing activities are going to be reported on by or before March the 15th of 2023. So this is an example of how your timeline would work for 2022 real world testing. Next slide, please. All right, now while the previous slide addressed a specific year of 2022 real world testing, this slide sort of addresses the life cycle. I go into great detail on this example in previous webinars, but I'll just say, if you pay attention to the fact that this is a rolling cycle where real world testing occurs on a yearly basis, okay? So every year you have to conduct real world testing, but the planning, conducting, and reporting of real world testing for any given year is going to overlap. Those activities are going to overlap. So if you see here, 2022 real world testing is described, 2023 real world testing is described. If you take a look at 2022, as you're conducting real world testing and executing your plan that you submitted by December 15th of this month, you're going to go out and you're going to implement that plan throughout 2022. But when August 31st rolls around, all of your health IT that's been certified by August 31st of 2022 has to be covered in your 2023 real world testing plan. So any active certifications that you have out there August 31st of 2022, you're going to make sure you address those as you're planning for 2023 real world testing. And you're going to more than likely be wrapping up the plan that you have for 2022 real world testing as you're planning for the following year of 2023. And that plan for 2023 is going to be due to be made publicly available on Chapel no later than December 15th of 2022 as you're wrapping up that year's real world testing. So this just describes the type of overlap that you're going to have with the conducting real world testing, planning for the current year, planning for the following year, as well as submitting your test results after you've already wrapped up real world testing for previous years. Next slide, please. Okay, so this is just basically a recap of the plan results and deadlines. As mentioned, every year, real world testing plans must be made available on Chapel by December 15th. Every year, real world testing results must be made available on Chapel by March 15th. And for both testing and results, ONC ACBs determine the date by which you need to have those to them in order for them to conduct their completeness reviews before they're made publicly available on Chapel. Next slide, please. Now, to assist in developing your real world testing plans, we note that we did make an optional template publicly available on our website, where we put this together to help in the creation of real world testing plans and outlining all the necessary elements for submission. Each section is going to provide an explanation of what the requirement and how to lay out your response. And we just note that ONC ACBs may also have additional requirements for submission or formatting. And so you just want to make sure that you work closely with your ONC ACB when making sure that your plan is complete and submitted and ready to be made publicly available on Chapel. Next slide, please. All right, now we have some resources out there. The first, the one that I want to specifically point you to is the Real World Testing Resource Guide. This resource guide also aims to assist developers in organizing the required elements related to the submission of their plans, making sure that it's complete and able to pass through in order to be made publicly available. It provides clarifications on timeline requirements, details on the plan elements needed to meet the requirements, guidance on special considerations for unique products, customers, and/or settings. And we also have some sample scenarios to illustrate the creation of a real world testing plan one of which is going to be specific to real world testing for a single criterion, and then the other is going to be specific to real world testing for multiple certification criteria. Next slide, please. All right. And to wrap up, just want to point you guys to all of the resources we have out there. We have tons. We have a fact sheet out there that gives you a snapshot of what real world testing is and the requirements related to it. We have the plan template that I just mentioned, the resource guide I just mentioned. We also have a real world testing certification companion guide, and we have previous webinar recordings and slides where we have been doing a lot of education and outreach around real world testing geared towards developers to help you understand exactly what you're supposed to do. So we recommend, if you're not familiar with the details of these requirements, that you take a look at the recordings that we've done this year on real world testing. Next slide. So I am going to go ahead and pass it over to Papia Paul to go over CHPL.
Thank you, Asara. So I am Papia Paul, a public health analyst here with our program administration branch and an ONC lead for the Certified Health IT Product List, also known as the CHPL. I'll be giving a quick overview today of an upcoming effort where we'll be giving certified health IT developers a new role on the CHPL that'll permit additional access. Next slide, please. So as you might already be familiar, ONC's CHPL is the authoritative and comprehensive listing of all health IT that has been successfully tested and certified by the ONC Health IT Certification Program. It is a publicly available resource, and so it can be accessed at the web address that's highlighted here, chpl.healthit.gov, and no registration or sign up is required to search the CHPL or use most of the available features. However, again, we're creating a new developer role to give certified health IT developers, so meaning only those developers participating in the certification program, logged in access to the CHPL. So that'll provide additional functionality and also help streamline the processes for meeting certain program requirements. Starting in January 2022, and more specifically mid-January, ONC will begin inviting the contacts for active certified health IT developers to register on the CHPL. And after today, we'll continue issuing reminders through the various certification program resources that we have. We'll also be working with the ONC authorized certification bodies, or ONC ACBs, to make sure that all developers are aware of the registration timeline as well as the process. And the first program requirement that we'll be leveraging this new CHPL developer access for is to facilitate the electronic submissions to meet the attestation's condition and maintenance of certification, which requires that certified health IT developers provide an attestation of compliance as specified in ONC's CARES Act final rule. And per the rule, the first 30-day attestation window, as a reminder, is set to open April 1st, 2022. And we'll also have more information on this, but in the meantime, we do encourage you to reference the Attestation Certification Companion Guide, or CCG, available on our certification program website, just as a refresher for this requirement. And for reference, we've also included the direct link to that CCG, which is also embedded here. And these slides from this presentation will be available for everyone after this presentation. But as an immediate next step, we've been asking certified health IT developers to ensure that their respective ONC ACBs have the most up-to-date information, meaning a name and an email address for at least one contact, though you can certainly, each developer may have multiple contacts. Email will be the primary method that we'll be using for inviting users to register on the CHPL. And once a developer has at least one contact registered on the CHPL, that user will be able to invite other users within their organization. And just as a note, in case there's any concern, contact information shared with the certification program as part of this developer access effort, it won't be shared publicly or for any purpose outside of the program. The quick clarification here is that public-facing and internal contact information can be different. So each certified health IT developer has a contact and contact information that is required to be published on the CHPL alongside that developer's health IT. But unless the developer specifically asks its ONC ACB to update that required public-facing contact on the CHPL, Any contact information shared for granting access to developers on the chapel, again, that will not be made public. It'll be for internal use only. So lastly, again, as a reminder, as mentioned, we're aiming to start inviting certified health IT developer users to register the chapel starting in mid-January. So please continue to watch out for more details from ONC as well as your ONC ACB. All right, next slide, please. And with that, thank you all. I'm going to go ahead and turn it over to my colleague, Keith.
Thank you, Papia. Yes, hello, everyone. This is Keith Carlson. I am a IT specialist in our tools and testing branch. I am Fire R4 certified, and I serve as a subject matter expert on our API criteria and privacy and security criteria. So I'm going to be starting us off here talking about some inquiries we have received through our centralized feedback system, or CFS, related to the G10 API certification criterion, which is, our standardized API for patient and population services. A couple points of clarification before we get into these. First is that these are just a subset of many issues we have received, but we kind of cherry-picked some issues that required like test tool updates or CCG clarifications to, hopefully give you a little bit of insight and background on, where some of these CCG clarifications come from, and just, talk more to the G10 criterion. And also, please, hopefully, this is a helpful explanation for folks, but please be sure to put questions in the Q&A box and stuff. We have colleagues in the background ready to answer. So with that, we can move to next slide, please. So this first, we're going to talk about an inquiry we received that kind of touched on the US Core implementation guide and some specific data absent reason elements. So next slide, please. So first, just some context to set up this inquiry that we'll talk about in the next slide. But just going to talk about some relevant ONC certification requirements in G10, and then a very specific relevant section of the US Core implementation guide. So in the G10 API criterion, we have data response requirements that are kind of summarized in these first two bullets here. So, in regulation, in summary, these say that certified health IT modules must respond to requests for a single patient's data according to the FHIR and US Core implementation specifications. And then we also make clear that all data elements indicated as mandatory and must support by the standards and implementation specifications must be supported. And then, again, this background on the US Core IG, this really dives deep into one part of it, but it is kind of important. It is an interesting nuance that shows kind of these questions that we get. So we're looking specifically at some US Core observation profiles, and it was pointed out to us that some of these profiles contain must support data absent reason elements. For example, there is a top level on the observation resource, there is an observation.dataAbsentReason element marked as must support. In the US Core implementation guide, I forgot to say, it's important to mention this is in version 3.1.1, which is the adopted version in regulation. It is different between versions, but our adopted version has these must support data absent reason elements. And then some observations have component elements. That's how they record their values. And so those, as applicable, those component elements also had data absent reasons. And so the Inferno testing tool, which Inferno is our, G10, ONC supported G10 testing tool, was looking for at least one example of each of these elements in some observation resource returned by the server under test. This is how Inferno tests for must support elements. It wants to see that the server can return it in some case to just kind of prove that hey, I can support this because I'm returning it back. Inferno acts as a demanding client connecting to a server that it is testing. So with that, we can go to the next slide. Next slide, please. Thank you. Perfect. So yeah, we received an interesting inquiry around these, someone who called out these must support data absent reason elements and asked for some clarifications. This inquirer pointed out that, or asked, for certification to G10, how is a system that never supports observations without a value supposed to demonstrate support for data absent reason elements? You know, this inquirer suggested that for many systems, if an observation is not recorded, the observation resource will not exist. And so, you know, after doing our deliberation internally and kind of reconciling this, we came up with this answer, which, you know, I've just broken up into bullets for readability on this slide, but all of this information has been published to the G10 CCG. You know, this was how this CCG clarification was born. And really the answer to this inquiry is this first bullet. This is the, you know, short summary of what we responded. You know, we said that for ONC Health IT certification, Health IT developers that always provide HL7 FHIR observation values are not required to demonstrate Health IT module support for data absent reason elements. So essentially, the requirement was relaxed a little bit. And the Inferno testing tool has subsequently been updated in one of the more recent releases to no longer fail a server under test if it never sees these specific observation data absent reason elements. But these last two bullets are very important because, you know, the second one here, I'm not going to read through it, but it just literally puts in quotes these specific resources and elements that we are talking about in this situation, because this is a very narrow carve out we're making for these specific observation resources that you do not need to demonstrate support for the must support data absent reason elements, but that is only in this case, right? And the last bullet here hopefully drives this home in saying that Health IT developers are still required to adhere to and demonstrate Health IT module support for the missing data section of the US Core Implementation Guide. You know, this is just saying that, like, outside of these specific observation data absent reason elements, there are tons of other resources in the US Core Implementation Guide, tons of other situations where missing data could be present and still needs to be handled. None of that is not all relaxed. It is just in this, you know, one situation. And so this was, you know, one example of an inquiry. We're going to keep talking about these, and I'll turn it over to my colleague Johnny to kind of go over a couple more with you all.
Great. Thank you so much, Keith. We can go to the next slide. I'm Johnny Bender. I'm with the Tools and Testing branch, and I work with Keith Carlson and Scott Bohan, primarily on the G10 certification criterion. And I'm also the SME for the public health certification criteria F1 through F7. And so today we're going to be talking about another inquiry we received that we provided a resolution on. And this is the US Core composite OR search. We can go to the next slide. And so just to give some background on this issue, so the requirements that we have in the G10 certification criterion include that Health IT modules have to respond to requests for a single patient's data according to the adopted implementation guides and standards, including USCDI, FHIR R4, and the US Core Implementation Guide, including the mandatory capabilities in the US Core Server Capability Statement. So that's part of the US Core Implementation Guide. And as part of this capability statement, the US Core Implementation Guide CareTeam profile contains a shall requirement for composite OR on search on CareTeam.status, so the element status. So essentially the server has to support the ability for a client to search on multiple statuses. So a client could say, for example, give me all CareTeam resources with statuses of active or inactive, and the server should be able to handle that search. The way that we had implemented this in Inferno is that generally we like to confirm the results of the searches that are performed to ensure that the searches are performed accurately. And so by default, we had implemented this as, perform the search, and then evaluate the results and ensure that we see more than one care team status to meet the composite or requirement. So for example, a server returning 2 care team resources with statuses active and inactive to correspond with the search. And so we can go to the next slide. And so we got some inquiries about this. There were some systems that only supported a single care team resource that includes all care team members for a given patient, and systems that only support like one CareTeam.status element. And there's nothing in the implementation guide or in regulation that requires support for multiple care team status value set items, for example. So health IT developers don't necessarily have to support multiple care team statuses. And so the inquiries we got were that the health IT developers were failing this Inferno composite or care team test because they didn't support multiple care team statuses. And so we provided this response, and then it's a, oh, and we just made a correction to the Inferno tool. This one is not a CCG clarification because this was an instance of us of the Inferno tool just over testing, not based on the requirements in the implementation guide, but just to confirm that a search worked appropriately. So we provided this clarification that the composite or search on status is still a shall requirement according to the US Core IG, and the Health IT module must support this search and not throw an error or anything when provided this search. But there's no accompanying requirement to support multiple CareTeam.status values. So if a if a client were to search for multiple care team statuses and the server didn't have multiple, they would just respond with what they had, right? And so the Inferno test tool was updated to allow demonstration of composite or search on status using a minimum of one CareTeam.status value. And I will clarify too that if multiple CareTeam.status values are returned in the search, Inferno will still validate those, but it's not going to fail a health IT developer for only providing one CareTeam.status value. So it's obviously a little technical and detailed, but I think this kind of shows an example of what we have to deal with and clarify with these implementation guides. And we can go to the next slide. And so this one, we're going to talk about a clarification we provided a while ago on end user authorization of resource level scopes. And we can go to the next slide on this. So some background on this is that according to the ONC Cures Act final rule and the G10 criterion, we have a requirement that health IT modules must include the ability for patients to authorize applications to receive their EHI based on fire resource level scopes. So this goes above and beyond the requirements in the Smart Up Launch Framework implementation guide. We said in the preamble of the ONC Cures Act final rule that patients need to have the ability to authorize access to electronic health information at the individual fire resource level. So this is from one specific fire resource like immunization up to all of the fire resources that are required by the combination of US CDI and US Core. And the reason we did this was to give patients control over how much electronic health information they could authorize applications to receive, rather than it always being a blanket all or nothing, patients could at least start to control the amount of information they're providing to these clients. And I think it's actually a pretty progressive policy in the health IT space and the technology space. One kind of a missing piece is like a great standardized way of doing this. We added this requirement, and there's not specific guidance on a standardized way to do this, but this is just the start, and we're hoping that the industry does some work around this, and we'll absolutely be watching. So we can go to the next slide for the clarification and inquiry that we got on this issue. So this is so this is the requirement in the test procedure. The health IT developer has to actually demonstrate the ability of the health IT module to evaluate authorization request and request user input. We require it for patient-facing applications, including the ability for the end user to authorize based on FHIR resource level scopes. And we actually, as part of the test procedure, provided this list of resources that apply here because we thought this would help health IT developers that were implementing this. These are the US Core IG resources that are part of USCDI and that are primarily part of USCDI, not referenced by other US Core IG resources. And so these are under scope for testing and certification. So we can go to the next slide here. And this is an example of what this would look like in, we have this in Inferno in the reference server, but a health IT module would need to give the ability for patients to select from a pick list of resources to authorize. And so we can go to the next slide. So we got a lot of inquiries around this. One is whether grouping of resource level scopes is allowed. Some things are, for example, some FHIR resources are dependent on other FHIR resources and would cause issues if only some resources were authorized and others weren't. So they sort of warrant grouping. And then another point is that the list of individual FHIR resources will grow over time and become, I mean, you even saw from the previous screen, it's a lot of resources and become unsustainable from a UI perspective. And then also some questions around grouping resources together and presenting a blanket accept or deny choice to the end user. And then additionally, is it permitted to authorize for more finely grained scopes? So we can go to the next slide. And so the clarifications we gave in response to these inquiries was that we restated the requirement and regulation and the preamble is that health IT modules must include the ability for patients to authorize an application based on resource level scopes. But the health IT modules, health IT developers are not prohibited from presenting these authorization scopes in a more user-friendly format. So they can group resources under categories to make it easier for the end user, rename the scopes for easier comprehension by the end user because the FHIR resources admittedly are not very clear in some cases and would not be, may not be understandable by a patient or just a typical end user. And also health IT developers are permitted to use more finely grained scopes. But for this grouping and stuff, the ability for patients to authorize applications based on resource level scopes must be available if requested by the patient. And an example of this is like a link or a drop down in the bottom of the authorization screen that allows a patient to navigate to a place where they can specify what more finely grained scopes they want to authorize. And this is just, this ensures some consistency around this for now. And like I said, definitely encourage the industry to work on this. I think this is a very kind of important thing for patient control over their health information, and we'll certainly be monitoring this in the future. I also want to say that I'm sure there's an overlap between the Inferno Tech Talks and this group here. We had a discussion about sort of transparency for the G10 clarifications that we make on the centralized feedback system yesterday. And we will, work to, always try and share the clarifications in a generalized way that doesn't, share any proprietary information or anything. And we'll try to make these more transparent moving forward. So keep an eye out for that. And with that, I'm going to pass it over to Emily Zhu. So thank you so much. Emily, you may be on mute if you're talking.
Hi, hello. I'm sorry. I apologize. Thanks, Johnny. Hello, everyone. I'm Emily Zhou. I'm a public health analyst from Tools and Testing branch. I'm going to go over some of the recent B3 prescribing criteria inquiries and NCPDP ERX test 2 update today. Next slide, please. Some vendors have reported issues with failing the renewal scenario 1, 2, and 5 tests on the ERX test 2. The identified issue is that the system under test, SUT, is pulling medication names from FDB or multiple drug database, which may host different medication names from the names expected by NCPDP test 2, since NCPDP test 2 is using a different source for its medication names. So in this particular case, the request is for naloxone 125 mcg oral tablet, but in SUT system's response, it is sending naloxone 125 mcg tablet with parentheses 0.125 mg, then parentheses. So per NCPDP script IG, if anything except the refill count in the medication response differs from the request, the system must send a replace response. Because of the medication name discrepancy between the request and the response, it caused the response to be replaced instead of approved and making the testing to fail the renewal scenario. And the reporter of the inquiry asked us if the test case could pass with a notable exception. So our response is, if the system in this case can show the application meets the B3 criteria requirements through replaces versus approved response type for renewal transaction, then the SUT should be able to pass certification test via a notable exception. However, we also would like to let you know, please do note that B3 criteria does require the use of RX norm codes where corresponding codes exist. RX norm provides normalized names for clinical drugs and links its names to many of the drug vocabularies commonly used in pharmacy management and drug interaction software. And it can mediate message between systems not using the same software and vocabulary. So we encourage House IT to download the RX norm files through the NLM National Library of Medicine download server to avoid a situation like this. The NLM download URL is embedded in this slide. Next slide, please. Thank you. Another thing we would like to share with you today is that ERX test 2 has just been updated to include a new medication history test scenario to support intermediary implementations on December 3rd. We added an intermediary connection and updated test stories and test steps to Pharmacy Benefit Manager PBM medication history scenarios 1, 2, and 3. As you may know, the original scenario flow is the prescriber creates a X history request and sends it to PBM, and then PBM creates a X history response and sends back to the prescriber. The newly added flow for the PBM medication history test scenarios through an intermediary includes prescriber creates and sends RX history request to the PBM via an intermediary. And then PBM responds with a status message to the intermediary, and then through the intermediary to the prescriber to acknowledge the receipt of the request message. PBM then creates a RX history response with query data and sends back to the prescriber. And then prescriber responds with a status to the intermediary, and then through this intermediary to PBM to acknowledge the receipt of the response message. So accordingly, the B3 e-prescribing criteria test procedure has also been updated to include this change, and it has been published on December 8th, which is yesterday. So with the new test tool release, SUT may choose to either use the original scenario for medication history transaction or use the newly added scenarios, but not both categories. And here are the screenshots of the test tool update and the B3 test procedure update there. Next slide, please. Thank you. NCPDP has posted the EX validation tool survey asking each stakeholder and user of the e-prescribing test tool for potential improvements and enhancements to the tool. The survey has been opened since November 1st and will be closed on January 5th. The survey is located at SurveyMonkey website with the URL listed on this slide. So once the survey closes on January 5th, we will review all comments and determines which, if any, suggestions will be implemented based on resources, benefits to all users, as well as other factors. So there are altogether 5 questions. 4 questions are required with mark star next to them, and the 5th question is optional for you to answer. The questions are asking for the improvement, enhancement feedback from you related to the context-based area, context-free area, general document section, and the e-prescribing to 017071's documents area. And then you need to leave your name, company, and the email address and submit the survey. We look forward to hearing from you all, and thanks in advance for your time and valuable input. With that, I'm passing to my colleague, Scott. Thanks all.
Thank you, Emily. Hello, everyone. This is Scott Bohan from the Tools and Testing branch. I work with my colleagues to support the API and security and privacy certification criteria. All right, we can go to the next slide. So I'm going to cover a question regarding the D12 encrypt authentication credentials criterion. If you have any questions about this criterion, please submit a question to the panelists or through healthit.gov. The D12 criterion is an attestation criterion in which a Health IT developer attests if their Health IT module stores authentication credentials in accordance to adopted standards. The standard referenced in the criterion is the FIPS 140-2 Annex A standard, which contains cryptographic encryption and hashing algorithms. This question asks if cryptographic hashing of the stored authentication credentials is sufficient to meet the requirements of the D12 criterion. Next slide, please. The regulation preamble provides clarification for this question. The preamble states encrypting authentication credentials could include password encryption or cryptographic hashing, which is storing encrypted or cryptographically hashed passwords, respectively. The preamble clarifies that encryption in the context of the D12 criterion refers to both cryptographic encryption and cryptographic hashing algorithms in the FIPS 140-2 Annex A standard. Therefore, storing authentication credentials hashed by a hashing algorithm from the adopted standard is acceptable in fulfilling a yes attestation for this criterion. I'll now pass back to you, Sean. Thank you.
Thank you, Scott. So that does it for our agenda. We have about 9 minutes left. So I was going to open up the floor for 1 or 2 questions, asking that you use the raise your hand function. Rana, I see you have your hand raised. Jennifer, could you unmute Rana, please?
Yeah, Rana, you can go ahead and unmute and ask your question.
Rana, did you want to ask your question?
I apologize. It was just clicked by mistake. I apologize.
No problem. No problem.
Thank you.
If anyone else has a quick question you'd like answered or comment you'd like to share in the next few minutes, please use the raise your hand function and we will unmute you. Jennifer, can you please unmute Gail?
Go ahead, Gail.
Gail, did you have a question that you wanted to ask?
Sorry. Oh, I had to unmute. Can you hear me now?
We can hear you.
Yeah, okay. So you brought up these various clarifications. If we have passed any of these measures, then can we assume that these clarifications don't apply to us? And if we haven't passed them, these clarifications are only if we plan to go for them. Is that an accurate statement? I can't hear you. Can you hear me?
Yes, we can hear you.
Did you hear my question?
Yes, I believe so. So the clarifications that we provided are, speak to the requirements in the program. I don't know if anybody else can help answer this.
So I think it's going to somewhat depend on the nature of the clarification that is issued. Some of these things are issued because they are clarifications for folks who are trying to go through testing, and they are flexibilities that are provided for in these particular areas. There are some other clarifications that I think clarify for some folks that there are must-dos. And in those areas, those must-dos are usually incorporated within the standard, so they are not optional. We refer to that particular standard. So it's hard for me to give you a blanket, like, all of these just apply for anybody going forward. It may, however, be the case that if you have already tested to a particular measure or certification criterion, that you don't have to go back and retest that. You just have to make sure that you are conformant or compliant with what the requirements are. Does that help?
Yes. So like, for example, in the case of G10, where there are must support, that is only if we are going for that measure. This is not like a new thing that everyone has to go for, the G10.
Oh, absolutely. No. Those must supports are things specific to the standard that is referenced in that certification criterion. So if you are not certifying to G10, then that is not a requirement for you. It's just if you are going to certify to G10 or have certified to G10, then those are must supports.
Okay, thank you.
And then I wanted to just provide some additional commentary on a question by Lisa Nelson about the expectation of consistency for the interface for setting profile level scopes would be helpful to users. And I think we totally agree. I tried to mention this a bit during that discussion. Totally agree. And that's why we're at this point, there's not a lot of great standards guidance out there to point to. So that's why we're kind of leaning on a functional requirement and allowing health IT developers to innovate in this area. But we would love to see some industry work and alignment around some standard practices for presenting these choices to patients. So yeah, definitely encourage that.
I did want to say, sorry, this is Rob. I just did want to say we have a couple of open questions about e-prescribing in the Q&A due to technical difficulties, which hopefully we've hid most of from you. But we've had some folks that have been cut off of our webinar. So apologize for not being able to get to those, but our e-prescribing expert has departed the chat. If you don't mind following up through Jira with those questions, we will make sure that we'll get an answer to you. Apologies to not be able to do them on the fly.
Yeah, and I can answer part of one of these questions from Uday, I believe. Yeah, so Uday, the question around what is the default fire resources enabled if patient won't select any options or won't answer. So if a patient goes in and does not select any fire resources, then the app will not be generally will not receive authorization for those resources. Health IT developers can implement this how, since this is a functional requirement, they can implement this how they would like, but I would expect that the application wouldn't receive any of the non-authorized scopes. And so the app just wouldn't function, which speaks to the inquiries we got around sort of creating like a default authorization screen, which kind of makes things work and makes things easy for the end user, so they don't end up unselecting things that would maybe cause the app to fail. But yeah, so just wanted to add that in there.
So we're closing in on the end of the hour here. I just want to thank everybody for taking part. Hopefully this or parts of this were useful for folks. Did want to remind folks that if you do have follow-up items, there is Jira. If you go to inquiry.healthit.gov, there are various things that you can use to submit questions under different categories, and we will make sure that we get those to the right subject matter experts. Also wanted to just say that for future agenda items, and I don't know if you have a slide on this, Sean, we have talked about looking at a couple of different things to walk through with folks. There obviously are some new functionalities within Chapel that we were thinking about walking through. There's some feedback that we thought about getting from all of you about how some of the tooling is organized on ONC's website as we think about doing some shuffling in that area. But we would love to get some feedback from all of you as well as to what might be useful things to cover. And that would be great actually throughout the coming year. Like I said, there's a number of things related to Cures Update requirements that are coming for everybody. So if there is education that we can do, fact sheets that we can do, feedback that you want us to hear, we would love to get that from you. And you can either send that to Jira here, inquiry. There's another category where you can put that information in, or you can reach out to any of us. There is an ONC information box. Sorry, Sean, do we have that? We probably don't. We'll follow up and send to anybody, but I will put my email in the chat. And if anybody has suggestions for future topics, please feel free to email me. I will be happy to think about those for future agenda items. So Thank you all very much and have a great day.